I welcome you all to OrthoTV online in collaboration with Pediatric Orthopaedic Society of India. This is the 7th webinar in our Posi series. And today the moderator with us is Dr. Taral Nagda. And we also have Dr. Paulo Selber from USA and Dr. Ratna Maheshwari and Dr. Samir Desai from Mumbai. So over to Dr. Taral Nagda.
Hi, so welcome everyone to the 7th Posi webinar. Thank you all for watching these webinars in a large number. This is the 7th one in the series, and the last few webinars have seen more than 1,500 attendees. So we have here Dr. Dhiren Ganjwala, who's president of Posi and who's the curator of this webinar series, and ably supported by Dr. Sandeep Patwardhan, who's the secretary. He's also here. Today for the webinar, we have two young enthusiastic minds who are going to take you through the journey of crouch gait, Dr. Ratna Maheshwari and Samir Desai, both pediatric orthopedic surgeons. And I'll request Ratna to share her screen and introduce the topic and the speaker.
Ratna has disappeared.
Okay, no.
I have to maybe wait till she comes back. What happened?
All right. So till the time Ratna comes, what I want to show here, these are some of the webinars we have had. We had the first one on Monteggia fractures with Mark Camp from Canada, and then meningomyelocele by Mohan. CP hip was covered by Reiner and Shredder across the continents. Salil Upasni gave us a very good webinar on Perthes disease. We had two pediatricians from Bangalore talking to us about COVID-19. And last week we had Mary Thakkar who spoke to us about benign bone tumors. And each of these webinars have seen more than 1,500 attendance. And those who want to watch the past issues can log on to Posi website, www.posi.in, or they can go to OrthoTV website, www.orthotvonline.com, and watch this back issue. So it's a rich amount of information which is shared by Posi. It's an initiative. So I request Ratna now, who's logged in, to introduce the topic, share your screen, and also introduce the speaker. Both Ratna and Samir have been chosen because they have worked with Paulo and probably know how he thinks, his jokes, and probably will be able to grill him better during question and answer session. Paulo, whatever you have done to them in their training years, they are going to give it back to you today.
Okay.
So,
meanwhile, you can also announce the next two webinars.
Yeah. So the next webinar is not far away. It's tomorrow, and it's going to be on DDH. It's going to be moderated by Alari Karujis, and we have two very eminent speakers, Dr. Shankar Udpav from USA, and we have Kishore Malpuri from Canada, talking about management of DDH in first 3 years. I feel probably Ratna has some trouble joining. So what I would do is, without making you to wait more to hear what Paulo thinks about crouch gait, I'm going to invite Paulo Serber.
She's in.
She's in.
All right.
Yeah, Ratna.
Ratna, can you share? I think she has an internet issue. Can we directly go to Paulo Selber and then come back to her?
Yeah, she is here.
There she is.
Hi, Ratna.
Hi, the internet suddenly.
Yeah, can you share your screen?
Yeah. No problem. Share your screen, and now you can introduce Paulo.
Yeah, hi. Welcome one and all to the 7th webinar of the Pediatric Orthopaedic Society of India. We have with us Dr. Paulo Selva today, and he's going to speak to us about patella tendon shortening and distal femoral extension osteotomies. Are these rogue surgeries in a way? Paulo is an assistant professor at Columbia University, New York, and the director of the Gait Recovery Center there. He's done his medical schooling and residency in Sao Paulo, Brazil, followed by fellowships in pediatric orthopedics, cerebral palsy, and gait analysis at Children's Memorial Hospital in Chicago and the Gillette Children's Hospital, Minnesota. He's regarded as a leading expert in cerebral palsy and gait. He's established gait analysis lab in Sao Paulo and in Sydney at the Children's Hospital at Westmead. He's worked in Australia for many years at the Royal Children's Hospital in Melbourne and the Children's Hospital at Sydney. I've had the pleasure of spending a year with him at the Royal Children's Hospital back in 2015, and I have very fond memories with him in the operating room and the gait lab. Suffice to say, he is a Brazilian dynamite, outspoken and quick-witted, yet very conservative in his surgical approaches. One can call him the hamstring messiah, and he's been relentlessly advocating saving them in surgery. He's a proud student of the legendary Jim Gage, whose stories he always shares with great fondness. I think, and correct me if I'm wrong, that he's also coined the word dosing while referring to interventions in cerebral palsy, and that singular word holds a lot of meaning when we manage these children. We're really honored to have you with us today, Paulo, for this webinar. When we speak of crouch and cerebral palsy, there are a couple of areas where there is clarity of thought and action, and I'll just highlight those areas. One, that it is a gait pattern with knee flexion, hip flexion, and ankle dorsiflexion. The hamstring may or may not be tight. Calf lengthening, iatrogenic or otherwise, can potentiate crouch or even cause it. It is a problem of liver-arm dysfunction. There are rotational issues in femur, tibia, and feet. And they are
Excuse me, Ratna, we cannot see your screen.
Okay, I'll just try again.
Now we can.
Slideshow?
Yeah. Now?
Yes.
Okay, as we speak of crouch and cerebral palsy, there are certain areas which are very clear. There's clarity of thought and action. One is that it's a gait pattern with knee flexion, hip flexion, and ankle dorsiflexion. The hamstring may or may not be tight. Calf lengthening or weakness can potentiate crouch. It is a problem of liver-arm dysfunction. It overloads the extensor mechanism, causing patella alta. And moderate to severe crouch is managed by distal femoral extension osteotomies and patella tendon inflammation. So before we go over to Paulo, I'd just like to tell all the audience members that you can start sending your questions on WhatsApp. The number is on the screen. It's 9320329888, and we'll take them after Paulo's lecture in our Q&A. So Paulo, over to you. You are the superhero here. Tell us, why do you feel that supracondylar extension osteotomies and PTAs are rogue or villainous surgeries in a way?
So I would request Paulo to share his screen and start his talk.
Good evening, everyone. It's a really a privilege for me to have been invited for this webinar. I know how successful it's been thanks to Dr. Duran and Ratna and Taral, Samir, and others, and of course with the support of the Pediatric Orthopaedic Society of India. I have made India sort of my home a few years ago when I first visited it. I've had the opportunity to work with many people from India, and I always adore to be around you. Your sincerity, your kindness is unsurpassed, and I learn more than I teach every single time I go to India. When Dr. Duran asked me to choose and pick a theme for this webinar, I thought for a moment, for a day or two, And I thought about the stuff that concerns me in the treatment of cerebral palsy. As you know, I have been involved in this area for more than 25 years and solely in this area. And it feels like it doesn't matter how much we learn and how much we share and how much we teach and learn again, there's still a lot that goes astray, even in this day and age. So I chose the title of this talk as Patellar Tendon Shortening and Supracondylar Extension as Osteotomy. I'm asking you all, are these rogue surgeries in a way? And what I'll be trying to do here is to tell you the history and do some conjectures on the failure reasons for these techniques. I have no conflict of interest in relation to this presentation, but I have to disclose to those who don't know me that I am a fan of historical facts, and I really, really love a good story and a joke. I can never start any of my talks without mentioning these three mentors. You have many people know the three tenors. I know the three mentors, Dr. Ivan Ferreto in Brazil, Dr. Luciano Diaz in Chicago, and Dr. James Gage in Minnesota. These three men were the people who shaped my views, my knowledge, my experience, and much of what I am these days. And I am forever thankful to them. Much of what I'm going to be telling you today is what I've learned from these three amazing doctors. So why choosing the subject again? I chose it because I think there must be serious concerns about the direction this technique has taken. And I would dare to say yet once again. And you'll understand a bit later during this talk what I mean when I tell you a little bit about the history of patellar tendon shortening. I also chose this thing to try and remind orthopedic surgeons that treat crouch in cerebral palsy of two very crucial historical facts, in my opinion. The first one is that patellar tendon shortening was used and it was proposed by a lot of people in various centers across the world, in Europe, in China, in India, in the United States, in South America, way before we started promoting it again in the mid-90s. This patellar tendon shortening idea has been around for at least 5 decades, if my research is correct. And the second important thing that I'd like to remind you all is that in those days, most of those centers, if not all of them, and most of those authors, if not all of them, abandoned the technique. And they abandoned this technique because it had significant failure rate and horrible long-term complications and rates. So why did we consider it again in the 90s? Well, that's the story that I'm going to tell you, and I hope you enjoy it. So let's talk a little bit about the timeline of orthopedic surgery in cerebral palsy, how it evolved over the last 50 years or so. So in the 70s, basically what we had was polio-like or polio-inspired surgery. The good doctors from that era, they were doing a bit at a time, and they were mostly doing muscle tendon lengthening releases, which we now know can lead to a lot of crouch. One of the best things that I've ever read was this book, Operative Orthopedics in Cerebral Palsy, written by Dr. Sidney Keats from New Jersey. He was a genius, and he knew so much about cerebral palsy, and his insights were so amazing. However, he was inspired by poliomyelitis, and he was then treating cerebral palsy a bit like polio. But he already had the concept of dosing. He used to call it tailoring the surgeries to each patient. And he also told and talked about low volume and high volume cerebral palsy surgeons. In the 80s, Dr. Mercer Rank inspired us because he brought the concept of sagittal balance. He also brought the concept that we were doing too many surgeries in separate occasions and causing what he called the birthday syndrome. So we all know this term, every child, every year, they were spending their birthday either in recovery from surgery or in surgery or post-op or in plasters or something else. They never had a childhood because they were getting surgeries every year. So in the 80s, this was changed. We thought about Dr. Mercer Rank taught us about the sagittal balance, taught us about the birthday syndrome, but the trend continued. They continued to do muscle tendon lengthening, which produced a lot of crouch. Then in the 90s came the great revolution, in my opinion, a bit earlier than late 80s perhaps. We started learning from three-dimensional gait analysis. So we start doing less polio-inspired surgery and started doing more gait analysis-inspired surgery. And what did it mean? It meant that we kept the concept of sagittal balance, that we started understanding and correcting lever arm disease or lever arm dysfunction. We started to think more carefully about not lengthening muscles too much. And the result was that we had less crouch, way less crouch. So in the 90s, we had more gait analysis inspired surgery, less polio-like surgeries. Therefore, what that means is that we started doing less muscle surgeries. We corrected the lever arm, as I said. When he touched the calf, we avoided the Achilles. And we started thinking that we shouldn't do hamstrings because we know, and there are a lot of studies that show it, either as a side effect, which is mostly what the papers nowadays talk about. Every time we lengthen hamstrings, or very often when we lengthen hamstrings too much, the pelvis tilts forwards. And that, in my opinion, is dreadful. And primarily for those of us who see these children becoming adults, and we continue to see into adulthood, we realize how bad excessive anterior pelvic tilt can be for their continued ability to ambulate. So, in any way, in the 90s, we saw less incidence of crouch following the principles that we were learning from gait analysis. However, we still witnessed primary crouch, those children who had not or never had any surgery and they were still in crouch. We saw and continue to see, unfortunately, iatrogenic crouch, and primarily in this area where fashionable is to cut muscles and tendons through the skin again, which was a node concept that was abandoned in the 50s and 60s because they knew they had no control. And in our case at ACD back in Brazil, we saw a lot of residual crouch. These were patients that we were treating and they were still in crouch. So what happened? What was happening? We were correcting all the levers. We were sparing the hamstrings from lengthening and to try and preserve hip extensor power and preserve sagittal balance. We were transferring semi-T in those days and only lengthening semi-member noses. We were being nice and conservative to the plantar flexors. These are two of our favorite techniques for diplegics, the Bowman, which actually stretches gastrocnemius, and Strayer, who, much against what people think, it's not a muscle lengthening, it's a muscle shortening procedure, for it shortens gastrocnemius. We stopped doing tendon Achilles lengthenings. We were saying no to these dreadful operation in diplegics. And we're doing all this stuff at the same time, as per the concept of SEML, single event multi-level surgery. So we were avoiding the birthday syndrome. So based on the principles that we've learned from this book and this man, we noticed that our long-term results were excellent in many patients. We did not see these types of outcomes in those days any longer. In fact, this patient I just saw in New York a couple of weeks ago, she's now 27 years of age, and she had the beautiful percutaneous hamstrings that so many people are talking about these days 18 years ago. And it looked just fine in the first few years. But this is her now, someone who could have been a very, very good GM-FCS2 for the rest of her life. And he can't walk for too long without crutches because she simply can't control her pelvis, which is totally tilted anteriorly, and she can't control her knees and prevent them from going into hyperextension. Therefore, she prefers to walk in crouch. So despite the fact that we thought we were doing everything right, everything as taught by Dr. Gage, primarily in my case and in Brazil, we still saw persistent knee flexion contractures, primary crouch, iatrogenic crouch, and our own crouch. So this is the man that I worked with at AACD, at the Association for Assistance of the Disabled Child, Dr. Ivan Ferreto, who was the clinical director and orthopedic surgeon there for many, many, many years. Dr. Ivan, when I came back from Minnesota and we started the Gate Lab and we started doing all by the book, after the first year or so, he said, Paulo, we have done it all, and it's still not enough in some cases. I think it's the stretched patellar tendon. He said, we need to salvage it. We need to shorten it. I have done a few of those over the years, but it doesn't work very well. But now that we know about the levers, now that we know about sparing muscles, maybe now that we are fixing all those things, if we add it, it might work better. And this is when we started discussing these things in 1996. And that's how patellar tendon shortening and supracondylar extension osteotomy became what we call our rogue surgery. In the good sense of the word, it was our last hope. So a few years later, for the first time in this new era, we presented this little paper at Posi. And this meeting was very important to me because that's when I met Professor Kerr Graham, who then, and we started discussing my going to Australia. Dr. Ivan was retiring. Things in Brazil were changing, not in the direction that I was very happy with, and I decided to take his invitation. So this paper was well received then. We even got a little award for best digital presentation because for the first time, we presented a surgical technique at Posi digitally. The problem was that I moved to Australia, Dr. Ivan was retiring, and many other things happened at the same time. And this paper was never published in a peer-reviewed journal. I went to Australia and introduced it to Australia, convinced Dr. Kerr Graham. But in Australia, the population was well controlled and we didn't have many patients in crouch. So I didn't do many of these in Australia. But time fixes everything. However, the fact that we didn't publish this paper precluded us from expressing the following facts: that we were extremely concerned that this surgery would tighten rectus and quadriceps and might flex the hips. It might compress or increase the compression forces of the patella against the femoral condyles and produce arthritis. We never emphasized that it was meant to be the last option in older patients, and that we wanted to rotate the condyles and carry the tibia forward, and not to create a deformity of the distal femur in recurvatum. So we never had the chance to explain that to a lot of people. This is what I mean by recurvatin, this is what the osteotomy should do. This is what I see often. And this alters biomechanics of the extensor mechanisms and flexor mechanisms. It alters the center of rotation of the knee in regard the center of rotation of the hip and the ankle, etc. So this is our fault because we didn't have a chance to explain these things. So, and what happened since? It happened that nobody got to know that this is massive surgery with prolonged recovery. And a few years later, thank God, my teachers, my former teachers from Minnesota that were following and thinking about the same stuff, they published their first paper. This was about 8 years after we presented our results. And they then published their technique, which is slightly different than ours. But interestingly, if you see the title of our paper and their paper, we called it a salvage procedure for crouch. They called it a procedure for persistent crouch gait in cerebral palsy, which to me means sort of the same thing. When you have done all other measures and it hasn't worked, then you use these techniques. What happened after those papers? Well, it looks like the whole world uses it now. Well, that should be good for the children because the reports are not too bad. The results are not too bad. We know that. But what I've realized recently and going around the world and reading the literature is that more often than not, patellar tendon shortening and supracondylar extension osteotomy that we call rogue surgeries are used as the first option. It became a monster, in my opinion, a bad monster in many ways. And I'll tell you why. I found this paper on the internet. I'm not going to cite authors because it doesn't matter. This paper has 14 patients, and you can see the ages. There are 4 that are around the age that we think the surgery is acceptable, but most of them, 10 of these patients, are underage. Most of them, 10 out of 14, had had no surgeries before. And not only they had the very, very super dose of supracondylar extension osteotomy and patellar tendon shortening, but they had hamstrings and other muscles lengthened at the same time, which is something that we very rarely do because we know how powerful these surgeries are. So, and what about the other levers? These authors don't mention anything about other levers. And we're talking about 2s and 3s, and we all know that these patients have excessive femoral torsion and tibial torsion and plantar valgus feet. And these was never addressed. So what is the risk of surgical overdose when you do patellar tendon shortening and supracondylar extension osteotomy plus hamstrings lengthenings? Well, I can show you. This is one case that I found on the internet. And you may say, Paulo, but this is just a picture of someone standing. How can you tell this is an overdose? Well, I can tell you very easily that that's where his center of mass and his trunk is. That's where his arms obligatorily have to be, behind the trunk. And the line of the shirt probably tells me very well how the pelvis is, because he had a very powerful operation that extended the knee and a very powerful operation that weakened his hip extensors. So I don't want to sound pragmatic, but I see these patients as adults, and most of them will be in horrible pain using crutches or in wheelchair. And what about the growth plates? If you're doing surgeries like that or like these, when the growth plates are open, well, Gillette reported a lot of complications with primarily with the tibia, the tibial growth plate. premature closures, deviation of the tibial plateau, etc. So again, the folks from my friends and teachers from Gillette were honorable and honest. And 2 years ago, they published their long-term results, which I am sure are well-controlled results and studied with three-dimensional gait analysis. So what did they find? So they found that in one of the groups that they studied, they compared two groups, 37% of the patients still had crouch as young adults. They also found that despite the fact, and we know that, and we've known that now for a long time, that these rogue surgeries improve stand space knee extension and knee flexion contracture compared to other conventional treatment, in their opinion, they found that these benefits do not translate to improve activity, participation, or knee pain in early adulthood. So how have we evolved? So I told you we do less polio-like surgeries and more gait analysis-inspired surgeries. We prime and adore and thank Dr. Mercer Rain for the concept of sagittal balance. It's one of the most important principles in the treatment of cerebral palsy gait. We continue to do the lever arm correction, and we are very, very, very gentle on the muscles. So this is our lever arm corrections that we all do. We derotate femurs, we enlocate hips that are that don't look all that good. We derotate the tibias, we do things to the feet so that the feet stay in front of the knees and are good levers. Feet in cerebral palsy don't need to have a perfect radiograph of a marathon runner. They need to be good levers that are aligned with the knees and follow the line of progression of gait. So how have we evolved? Well, we even decreased our surgical dose at the hamstrings levels in the last few years. So, you know, and I've been talking about this forever, that this is my very favorite surgery in cerebral palsy, semitendinosus transfer, because it stops hindering the knee, it decreases the knee flexure moment, but it continues to act as a hip extensor and preserves hip extensor power. And there are a couple of articles in that regard. The problem is that many articles that follow these recommendations, not only they did semi-T transfer, but together with that, they lengthened semimembranosus. There's an article where they also concomitantly transferred gracilis and lengthened biceps femoris and said, see, semi-T transfer doesn't make any difference. The pelvis is still tilted forwards. Well, that's an overdose in my opinion. And then together with these more recently in the last few years, since this technology came to to the markets, we started doing guided growth. And Gillette again has published a beautiful paper in this regard. My only reservation is, or the only difference between our line of thinking and theirs is that we do this first, and if necessary, we do this. If we don't have enough time, we may do them at the same time. But to us, fixing knee flexion deformity in cerebral palsy always starts with this. So that's a little example that the other treatments, the ones that don't involve patellar tendon shortening and supracondylar extension osteotomy, can work. This is a dystonic athetoid child that was a GMFCS3. This is a few weeks after he had only semitendinosus transfer. And you may say, I hope you see his very flat externally rotated feet. And you may say to me, why didn't you do it at the same time? Well, because I'm scared. Dystonia, you need to be slow, small doses. So I knew that he had liver arm dysfunction, yet I only transferred his MT and nothing else. And he went from 3 to 2, which is absolutely very rare. You can see that what really changed was his FMS, given that his wheelchair is still there. And then a couple of years later, all I did was to derotate his tibias. I didn't touch his feet. And at the age of 18, which is this video now, the corrections are maintained. He continues to have full knee extension, but more importantly than all of the above, or all of what I said, look at his pelvis and his trunk. They're still sitting on top of the legs. So to me, you can only say that your results are acceptable and good if the trunk remains on top of the legs, if sagittal balance is maintained. So let's see if I can. So how have we evolved again? So whenever those surgeries are not enough, and sometimes it does happen, and that's when we go rogue. So we've fixed everything else before. We fixed levers, we fixed the hamstrings, we fixed the femurs, psoas if necessary, the calf with a small dose, the feet, correcting them in front of the knees and making them into good levers. That doesn't work. Then we can go rogue and do these things. You can see in this patient of mine that the growth plate was closed, femoral osteotomy is done. I was not overly happy. This x-ray is a bit rotated, but I think I did a little bit of that recurvatum of the knee, even though I brought the femur back. The chrono alignment was fine. So how have we evolved? We went from patellar tendon shortening and supracondylar extension osteotomy to patellar tendon shortening plus or minus supracondylar extension osteotomy as a salvage procedure for crouch gait and CP. Why plus or minus? Because with semi-T transfer and guided growth, if you do what I call crouch surveillance and you act on time, very rarely supracondylar extension osteotomies need to be done. Now, I'm not naive. I understand the contexts of different countries, of different parts of the world. And I perfectly understand that very often the children come to you at an age where it's really hard to recover. But I beg you all to think about this history, to think about these principles, because even in older children, very often you can get them out of crouch and not necessarily use or go rogue. So what are we doing today? We're doing just like in the beginning. We correct everything, and if it doesn't work, we then use these rogue surgeries called patellar tendon shortening and supracondylar extension osteotomy. Thank you very much for your attention.
Very nice. So I would request Ratna and Samir to be ready with the question. Paulo, it's been a it's a talk of the decade. It lasted 45 minutes, but it's going to change a lot of minds. More than 1,000 people have been attending this webinar. This adds to the list of the Posi webinars which I have held. This is the 7th webinar for people who have joined late. And this is on crouch, where Paulo was describing his thoughts on correction of the crouch gait. And what we understood, Paulo, is that, of course, there are answers, but with every answer, there is a question. And with every question, then there is going to be answer. And with that answer, there is going to be another question. And this process is going to repeat and repeat and repeat. What you thought, about a salvage procedure, the whole circle has come 360 degrees back to itself. So Dhiren and me, we have been the movers in this discussion, but the real seekers are Samir and Ratna, and I would request them to take over for the question and answer session.
Hi, Paolo. We usually take some measures in supine position and some measures in standing position. However, I always felt that walking and crouch are erect phenomena. I read in a paper that children with knee flexion in mid-stance, more than 20 degrees usually progress to crouch. So which test do you rely on for clinical decision making?
Certainly not on the popliteal angle. We've shown, and there's a paper, if you go to Journal of Pediatric Orthopaedics, American volume from, don't get me wrong, I think from June or July of the year of 2000, you see a paper from Milwaukee, which says that physical examination doesn't correlate very well with gait findings through the gait lab anyway. And coincidentally, on the same POSNA meeting that we presented the patellar tendon shortening and the osteotomy, we presented another paper saying exactly the same, that physical examination doesn't correlate with gait findings very well. And of all of them, popliteal angle is the least useful. It only correlates, if I remember our paper well, and the Milwaukee paper well, it only correlates with knee extension at terminal swing and knee flexion in mid-stance when the popliteal angle is more than 70 or 80 degrees. So I never say that hamstrings are tight until I see popliteal angles close to 80 degrees. Until then, I think they're as good as mine, my own popliteal angles. And people have to understand that we measure popliteal angles with the hip flexed at 90 degrees and the knee flexed at 90 degrees, but we walk with hip extension and knee extension. So there's no way that measurement correlates, in my opinion, to the prescription of or the understanding that hamstrings are tight. And how many times have you seen popliteal angles that are close to 80 degrees and the patients have hyperextension of the knee? I bet the ones who have been in this area for many years have noticed that. So how does it correlate? So popliteal angle to me is a useless measure.
Yeah, thank you. Paolo, another interesting thing that if you take a survey of orthopedic surgeons, you will find that more than 70% of them would say that crouch and hamstrings are short, but that's not the case that's been proven. So in how many cases do you usually find that hamstrings are usually normal or long and not short?
Well, Scott Delp has a paper from many, many years ago showing that it's a paper with him and Ludias, if I'm not wrong, and they showed that hamstrings seem to be short in only a third of the cases. In 2/3 of the case, they either normal length or they're longer than normal. My problem is, my issue with hamstring surgery is that we tend to forget, in fact, we forget all the time, that the most important role of hamstrings in gait is to extend or to help to extend the hips and the pelvis. So there are approximately 100 papers out there or more, because now papers are popping in every direction from all sources. But I counted about 100 papers that show that if you lengthen the hamstrings, you get more knee extension. There's absolutely no doubt about that. The problem is not that. We know that if you lengthen the hamstrings, the knees extend. But the problem is that when you lengthen the hamstrings, the amount that you really need to extend the knees to a good position, then the pelvis falls forwards as well. And Kerr and I have just wrote a little letter to the editor, which just came about in JPOA this month, actually this week, about a paper. And it was a very good paper. And they showed, look, see, we lengthened the hamstrings, the knees got better, and the pelvis didn't tilt in GMFS2s. It did tilt in GMFS3 in their papers. But then when you look at their results in terms of knee flexion, the knees continue to be flexed. So what happened in that paper, in our humble opinion, is that they used a very conservative dose to lengthen the hamstrings, which I think it's perfect, all right? But because it was conservative, it didn't solve the knee problem altogether. And but on the good side of this was that the pelvis didn't tilt. So, and that's us in 95 back in Brazil, or 96 back in Brazil. We were being very conservative and finding the problem. That same problem. This is 25 years ago, 25 years ago. That's when we started thinking about the supracondylar extension osteotomy. Instead of going back to the hamstrings, we know that lengthening hamstrings doesn't solve the problem. Dr. Mauro from ACD has just published a paper on the same JPO of May, comparing lengthening versus re-lengthening of hamstrings. And does it help? We all know, we have all known forever that it's not the way. The only reason Mauro was able to, and I don't want to put words in his mouth, the only reason I know that Mauro was able to write that paper was that because he, for circumstances, local circumstances, he had the two groups. People, you know, going, that's what I call really rogue, to go, in the bad sense of the word, to go there and re-lengthen the hamstrings again.
So Paulo, my question for you, with regards to anterior distal femoral hemiepiphystodesis, literature seems to suggest a very slow rate of correction, especially in the cerebral palsy group. So how promising is it in your opinion? What implant do you use? What is the surgical technique? Do you leave them slightly overcorrected? And what complications have you faced so far?
Okay. See, everything happens for a reason. You noticed in my talk that I said my first surgical dose for knee flexion is semi-T transfer. Then if that is not enough, I go for the what I call the second more significant dose, which is in our hands a guided growth. And sometimes if a child is is running out of time for growth correction or guided growth, we do semi-T transfer and guided growth at the same time. Now, what happened in this paper is, in a couple of other papers with guided growth, is that they're expecting the guided growth to fight against the hamstrings and other problems. If we have liver arm dysfunction, if we already have patella alta, if the hips are turned in, you cannot expect that guided growth will correct the problem on its own, because you could see that situation as a bunch of people trying to bend the knee and just one or two persons trying to extend the knee. All right. So that's why you need to think this in a way that makes sense. You need to take the forces out of the knee. Or am I saying let's do hamstrings lengthenings? No, you can't do that, because if you do that, you hinder the pelvis. In my opinion, and I'll continue to say it until the day I die, the best surgery for knee flexion deformity in CT, it's not panacea, and it definitely doesn't solve all the problems, is semi-T transfer. So if that's not enough, then you do guided growth. Then you see that the guided growth works better, because semi-T, I have the impression that in 80% of the patients is the main factor bending the knee too much. And if, in fact, if you think if you want to do an analogy there, it's not that the CEMIT wants to bend the knee. It's trying to extend the hip, but selective motor control and other things happening concomitantly results in this muscle actually bending the knee. So I think in our hands in Melbourne, I think guided growth worked well, primarily more recently. With the first apparatus that we had, the apparatus was a bit too high on the profile. And in many patients, it caused a lot of pain, to the point that Kerr and I and Dr. Abai, we stopped doing guided growth a few years ago, because the first implant that we had was, the idea was perfect, was the brilliant idea, the first idea, but the profile was a bit too high. When we had the second line of implants, and I have no conflict of interest with any of these companies, when we had the second set of implants, they came and the profile was very thin, and we started using that in those students. They didn't have much pain, and that worked brilliantly. We had done the CEMIT, so we had taken the evil force, if you want to call it that way, without compromising the pelvis. Now we had fixed the levers. Now the growth plates can be manipulated well. But don't expect that growth plate manipulation will solve the problem if the feet are turning 40 degrees east and west. It's not going to happen.
So that's a low profile 8-plate is what.
Yes.
And do you leave them overcorrected?
So one I have that when you are doing a differential growth, you have more posterior growth, less anterior growth. So you are decreasing the height of the femoral condyle anteriorly. Now, will this decrease the area and increase the pressure over patellofemoral joint? What will happen to patellofemoral joint because it's an intra-articular shortening which happens?
I don't know. I simply don't have an answer to that. I know what supracondylar extension osteotomy and PTS does to you in the long term. And the result, as you've seen, it's not all that great. So PTS and supracondylar extension osteotomy has to be seen as a salvage procedure, in my opinion. Growth, I don't know the answer to that question, simply because we haven't followed these patients long enough. I think we will only know the final results of these things in 10 or 15 years, when we continue to see them as adults and see if the pressure area and distribution in those joints has been altered enough to cause premature arthritis. That's a very good question. And I'm sorry, I apologize, I don't have the answer. And
would that be topic for your next talk after 10 years?
Yeah, if I'm still alive.
Okay. Samir, your
Hi,
question.
Paolo. Yeah. We see many children who have been treated with isolated TA lengthening at a very young age. Then in this condition, how do we manage these children, and do splints and piezo have a role in these children?
Well, I think the first thing we could do is to spray Lysol and bleach, like the president said, on those surgeons doing these techniques. Okay, that would be extremely helpful. I'm sorry I'm being politically incorrect, but that's my first thought: bleach and Lysol to those surgeons. Secondly, if you catch these children and they're still young, you can only have hope that the calf will tighten up. One way perhaps to help them tighten up is through the use of solid AFOs constantly, and not let them take one step out of the AFOs. But I don't have any data to show that that makes any difference in the long term. I've seen a few patients where I basically threaten the patients with life that if they took one step out of the brace for a couple of years, 3 years, I would be really mad at them. And it seems that it worked, but it could have been natural history, and they're growing, and the calves are tight. But it's interesting because even yesterday, I saw a patient through telemedicine from California. She's 50 years of age. She had a total knee replacement. She's the diplegic.
Where are my glasses on this?
She's a diplegic GMFS2. And she had Achilles tendon lengthenings when she was young. And I could just record her. This is a brilliant woman that works in a very fancy job. And she said, Dr. Selber, I can't stretch my hamstring standing because I have no power in my calves. So I constantly have to wear AFOs. Not AFOs. I constantly have to walk in a very stiff way. And if you observe her gait, she has a stiff knee gait, not because she has rectus spasticity, but she walks almost like a polio person, not because she doesn't have the quads, but she doesn't have the calves. So once they're done, it's really sad. And of course, we all know about the new fashion, which is the fancy percutaneous surgeries. So people are cutting these tendons and muscles without any control and bragging good results for the first year or two. But we are the ones seeing these kids when they're 5, 7, 10 years post-op. And let me tell you, we cannot recover them. What is the role of calf shortening in surgery? I have no idea. But as I told you, I love reading the past. And people have tried that. In fact, nothing that you do is new. Somebody way much smarter than us have tried everything already before us, way before us. And I don't know of a single report that says that thing works. So if somebody amongst these thousands of people who are watching us, listening to us, if they have the data and it's good data, somebody should publish this. But I have never tried. It's interesting, isn't it? Because in the 60s, we were talking about lengthening everything, releasing everything. And now in the 20s, we're talking about shortening everything because it's been over lengthened. Isn't it interesting how the story goes?
So Paulo, the next question for you about semitendinosus transfers. Is there a particular GMFCS level that you look to do them in? Like, is it reserved for 3 and 4? What degree of flexion deformity would you still attempt a semi-T transfer in? What might be the youngest patient where you've done the transfer? Are there issues of step length? I mean, what is your experience in long-term outcomes?
Yeah, these are all very, very, very good questions, Ratna. We could spend an hour, and you've heard the story about the semi-T. It was Dr. Jim Gage who taught me semi-T transfer, even in 1994 when he was a visiting professor in Brazil and I was a fellow there. Then I went to Minnesota, then became his fellow, and went back to Brazil and never actually realized that I didn't see any semi-T transfer in Minnesota the year I was the time that I was a fellow there. But I went back to Brazil, and even today, if Dr. Gage tells me to jump, if he tells me to walk, I jump and run. But I continue to do semi-T. In those days, I was overdosing my patients because I was doing semi-T and semimembranosus lengthening. I learned my lesson and I stopped doing semimembranosus lengthening, as I told you. But Dr. Jim Gage stopped, as per his own words, stopped doing this operation because it was limiting step length. Because if you attach semi-T to the femur, it's such a powerful surgery, eventually you can't flex the hip very well. And I can tell you that that's exactly what happened to my very first patient in Brazil. I put it so tight, and this was a patient from the northeast of Brazil, and he came after a year for gait analysis, and his pelvis was going like that because it was going posterior, 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 and his step length was very limited. So in those days, I faxed Dr. Gage saying, what have I done? What do I do now? And I remember he faxed back and he said, well, try to lengthen semi-T a little bit because the skid has grown and it's probably too tight. And that's what I did. I lengthened it intramuscularly, which with semi-T is not easy. And it improved a little bit. But what degree of deformity? I think anything up to 20 or 30 degrees has the right to have a semi-T transfer. Kerr and I and others have written, we think that knee flexion deformities are either too mild or too severe for hamstrings lengthenings. And I think that's probably the best thing I've ever written with Kerr. Pay attention to the sentence again. We think that knee flexion deformities are either too mild or too severe for the typical hamstrings lengthenings. So up to 20 degrees, even 30 degrees of knee flexion deformity, depending on the age, I always start with semi-T transfer, then eventually guided growth. What is the youngest that I've done? If I remember it well, the kid was 8 years of age, okay? And that was back in Australia. Kerr and Abai will tell the truth. In a few years, they'll probably show this pelvis badly posteriorly tilted because semi-T is too tight as they grow. So complications. I think the difference between what Jim Gage did, and again, this is a conjecture. I'm not sure. We haven't gone back and put the groups together. But I suspect that Dr. Gage used semi-T transfer to very mobile patients, perhaps GMFS 1s and 2s. And we tend to use semi-T transfers more to the end of the 2s going into 3s and 3s. I don't do it in force unless I have someone who is very slim, who's still keeping the potential for standing up. But sometimes I do. But the two groups are 2s and 3s. I think these are the ones. And the long-term outcomes, we tried to recently publish the paper of long-term outcomes, but we couldn't publish it anywhere because we didn't have a control group. Good old research like the parachute, and nobody accepted. So I'm hoping that when somebody else starts doing it the way we've been postulating, they will publish. But they have to publish semi-T transfer, not semi-T but lengthening everything else, because that's not gonna work.
So there is a question from the audience. Jayan Sampat from Bangalore is asking, when you do a semi-T transfer, how do you judge the tension? How do you know what? So is it an easy procedure? It's difficult. How do you do that?
Well, there's always a funny answer to that question. It's about 2.83 Newton.
Super. And it's not 2.83456, right?
No, it's 3.83 Newton. Well, that's the art of medicine. I learned through my own experience and through that case that I told you, my very first semi-T transfer at AACD in São Paulo, Brazil, came back a year later, and the step length was like 10 centimeters, and the pelvis was going posteriorly so crazy that I had to go in there and lengthen semi-T. And trust me, it was transferred and it was intact and moving. What I tend to do is, if I have someone who's young,
ही आता
I know
खणलेली
that the
माती
parents
म्हणतायत
are
तुम्ही
tall.
गटार खणल्याची माती रस्त्यावर न टाकता डायरेक्ट ट्रॅक्टर मध्ये टाकायची. उद्याची बात आहे ना. उद्याची बात आहे. हा तर मग आपल्याला ग्रेड उचलल्याशिवाय टाकतो.
We can't hear you. Yeah. Ratna, can you hear?
Taril, I think he has stopped because there is a lot of background. Is it from your end? Somebody putting mud in tractor?
Thank you. If I see someone young whose parents are pathologically tall, as I call them, you know, they're very tall, and I know that this child is going to grow a lot, but this kid needs semi-T, I harvest it as far as to the base so that I have a lot of tendon, and I transfer it as loosely as possible. And I don't care that the pelvis will tilt forwards a little bit in the first few years, 1, 2, 3 years. Eventually, it will tighten and the pelvis will go back. If I have a 14-year-old who's not growing much anymore, then you transfer a tendon like you transfer a tendon. You know, not too tight, not too loose, like our mentors taught us. But if you have to make an error, don't make it too tight. Okay? Because remember, muscles are spastic and they'll continue to be spastic for the rest of the lives of these patients. So if you transfer semi-T a bit loosely, it will certainly tighten up. Okay? And if you transfer it too tight, it's going to get too tight as the patient grows and ages.
Samir, unmute yourself. We can't hear you. Yeah.
Can you hear me?
Yeah. There are some centers that are advocating selective dorsal rhizotomy. Which child is an ideal candidate for SDR? I remember you telling us about 5 to 6 S's that a child should have.
So I've learned all of this from Gillette, and they've evolved. We have evolved. I think in Melbourne we didn't do as many rhizotomies as they do at Gillette, and I think, and I can only say from reasoning and from my heart, because we haven't followed, we don't have data to prove these. But I think the reason why we haven't needed a lot of rhizotomy in Melbourne, and Kerr perhaps will hear this and he can correct me and say that this is nonsense, but I don't know. But I think semi-T transfer is such a powerful way to improve knee flexion without compromising the pelvis. You saw my patient, dystonic and athetoid, nearly 10 years post orthopedic surgery. Of course, we didn't fix his athetosis when we didn't fix his dystonia. But did you see how straight and nice he was and balanced? I think when you can't get the knee right and the pelvis right and the foot right with orthopedic surgery, that's a real problem, and that's where the bad results happen all around us, and they're still happening. You know, here next to me here in New York, there is someone doing lots of perks, and we're seeing some of these patients, and it's not good. But back to rhizotomy, I think rhizotomy is a fantastic concept for now. I suspect that in 100 years, they will be looking backwards and say, oh my God, these people cut the nerves, and now all we have to do is to give this little pill or manipulate this gene or whatever. But that's what we have now. So if you have a child who has spasticity, tons of spasticity, who is relatively strong, who has good social support, who has the ability to rehabilitate post-rhizotomy, which is a massive surgery. I think rhizotomy should be done before orthopedic intervention, if possible. What's the golden age? Somewhere, I don't know, perhaps between 4 and 8 years of age, but I'm sure Dr. Tom Novacek and the JAP people may correct me in so many ways because they always know better, truly, because they have so much experience. But I think rhizotomy is a great thing. It does not replace orthopedic surgery, nor does orthopedic surgery replace rhizotomy in many cases. You know, even SEMI-T and other things, if you have a child, even at GMFSS2, whose Ashworth scores are going through the roof, orthopedic surgery is not going to be the answer. It might be the answer when spasticity levels have come down post-rhizotomy. The problem with rhizotomies is the problem with any other intervention in medicine. There have been rhizotomies and rhizotomies, criterias and criteria. There have been people who know what they're doing and people who don't know what they're doing, unfortunately. This happens in the building industry. This is humans. This is us. Ask me to do a total hip replacement on you. You probably won't want that because I have no idea how to do one. But some people just go and do it. And so rhizotomy is a complex operation, has a very specific role, in my opinion, which is not to decrease, not to abolish spasticity altogether. And we've seen in the past that in some cases people went into crouch, primarily if distal rhizotomy was very aggressive. So it's all about dose, okay? How much dose of rhizotomy you give, even though there are studies that show that dosing makes no difference in rhizotomy, which I certainly not believe. You know, you give a 100-kilo person a parachute this size or a parachute that size, and you see what happened. We could even do a randomized control trial with those, or even me. If you give me a normal parachute, I may never fall because I'm so small that I may never reach the ground. So it's all about dosing. I think it's a good operation. I think it needs to be indicated correctly, done by the right person who has experience, who understands gait, who understands which rootlets needs to be addressed more or less, etc.
Thank you.
Samir, the part 2 of your question.
Yeah. So is a child with SDR more prone for crouch due to element of weakness?
Sorry, I didn't understand your question.
Yeah.
So yeah, the centers which do more SDR also are the centers which have more crouch surgeries. So, you know, does it happen that SDR is a precursor for crouch because of weakness it creates?
As much as I understand it, technically it shouldn't. It shouldn't. I remember there was a paper presented at a CPDM, the American Academy of Cerebral Palsy, many years ago from, I think it was Dr. Mark Abel and his team, but don't quote me on that one because my memory is not as good as used to be anymore. But they showed that rhizotomy can produce and lead crouch, and other people have shown the same thing. And if you go too far down, L5, and you cut too much in L5, what you're actually doing is a TAL, a neurological TAL, a tendon Achilles length. And certainly you put this child in crouch as they grow. I suspect that if you have a child who has a ton of spasticity and lever arm dysfunction, oops. You have a child with lots of spasticity and lever arm dysfunction, and you do rhizotomy and you don't fix the lever arm dysfunction afterwards, or perhaps even beforehand, depending on the case, this kid is going to go in crouch. And is it the rhizotomy, or is it the lack of levers, or perhaps a bit of both? So I think crouch, I think the most important thing that I understood about crouch in through my mentors and through my life is that, and primarily from the patients and families, is that crouch is a multitude of diseases. Crouch is not one thing. You can be in crouch for many reasons. And I have a talk that I think I've already given in India once about the factors that can lead crouch: weakness, long muscles, operated muscles, lever arm dysfunction, selective motor control, equilibrium, poor vision. Even though there is a paper that shows that weight does not necessarily produce more crouch. That's one paper saying that. I don't believe in that, because I've seen my patients putting on weight and crouching as it happened. So crouch is not just crouch. When we see a child with crouch or someone with crouch, I think we need to understand where is it coming from. And we need to understand all the etiologies and then treat the etiology and not lengthen hamstrings like most people do, unfortunately.
So, Paulo, next question for you is with regards to the rectus muscle in crouch. Do you find the prone LE test reliable as far as clinical assessment is concerned, or do you rely more on the kinematic data or EMG data when deciding to operate on the rectus muscle?
Ratna, I'm starting to understand your questions. These are questions that I didn't know when you were a fellow in Melbourne, and I still don't know. And you're asking me them all again to see if I've learned anything. Look, I think the Duncan test is reliable. If you go back to Jacqueline Perry in her studies with fine wire EMG, Jacqueline Perry showed that when you trigger rectus through the Duncan test, you're also triggering iliopsoas. Okay. So how much of it is when you see the pelvis going up, how much of it is rectus flexing the hip or iliopsoas also helping? We don't know for sure, but I think it's a bit of both. But I think if it's there, you need to consider it. Okay. And then the other thing that is important is that during the Duncan test, you can also do it slowly. You do it quickly to elicit spasticity and mimic gait, because we all know that the knee flexes very rapidly in initial swing in gait. So rapidly to mimic that, and slowly we can see if it's contracted actually. You can see as soon as you start doing it very slowly, the hip starts to flex. Now, one thing that I've already said over there, and I'll repeat so that people don't forget, you can call it any way you want, but given that you are in prone and you're doing the Duncan, so the kid is facing to the table, tummy facing the table, prone position, why don't you use that opportunity and also try to extend the knee rapidly and see what happens to the hamstrings? Because the same way Duncan tests rectus in the quadriceps, you could do the opposite and extend it rapidly. But do more than that. Put your hands just distally on top of the hamstrings and see which one pops and tense the skin more often than the others. And then one day you tell me. So you can call it the reverse Duncan test. This is something, an insight that I've had of years ago. So if we're measuring spasticity through physical examination of rectus, why don't we do the same with hamstrings? The poor hamstrings, they're attacked and raped all the time, in my opinion. So let's test it, okay? Do we rely EMG data? Yes, I think we do, but we need to remember that Scott Delp showed, again, Scott Delp, one of the very brilliant people on this field, he showed that it's not only rectus activity in early swing. There's a tendency to think that if rectus is already active in pre-swing, that's when it slows down and delays peak knee flexion, or even curtails the range of peak knee flexion. Now, let me just say, and this will be pragmatic, and unfortunately people are still discovering it, but we have been saying that forever. Don't do rectus transfer in crouch, because you put them in more crouch, all right? You don't have to be very, very, you know, orthopedic surgeons can't think that way. We are brilliant. Don't do rectus transfers in crouch, because they're gonna, so there's a phrase that I like to say. You have to think of in cerebral palsy. Try not to forget this, if you will. I'm being a bit pragmatic, but in cerebral palsy, the stance phase is a duty, and the swing phase is a privilege. You have to fix the stance phase before you try to fix the swing phase. And not only that, like Kerr and myself and others have seen, very often when you fix the stance phase properly and the pelvis doesn't tilt forward and it's good, and it's not easy, we admit that, some of the problems of stiff knee gait in swing will disappear. So for many, many years now, I'd say probably for more than 10 or 15 years, we don't do rectus transfer at the same time as Samuels. And you didn't see them, Ratna and Melvin, because we've learned that very often we don't need to do rectus transfers a year or two down the track. I still don't know exactly what are the predictors for that. Some people have written papers on it, and they're all confusing, and I don't think they helped much. But I think that's an important principle that people should think about. All right. If someone is falling down in swing and stance, what are the privileges that they have to swing very nicely and bend the knee and swing? They're falling. Okay. They're activating everything that they can in front of their thighs in stance to prevent them from falling or collapsing even further. That might be the result. That might be the cause for why these people don't flex their knees very nicely in swing. But when you get the stance phase right, then they have the privilege to swing. Okay? So stance phase in CP is a duty. It's your duty, it's the child's duty, it's my duty. Swing phase is a privilege. That would answer your question, your next question. No, never, never, ever. What I have done a few times, do I do distal extension osteotomy, or supracondylar extension osteotomy? I don't do PTA, I don't advance the tendon, I shorten the tendon. That's how we started. That's why what I still do, because when you, I don't think, the problem is the tendon, not where it's attached. The attachment is still, is there any problem with the height of the attachment of the patellar tendon in the tibia? No, there isn't. It's still normal. Sometimes it breaks, but it's still normal. The problem is the length of the patellar tendon. So you go for the bank and rob the bank because that's where the money is. So I go for the tendon because I think that's where the problem is. Sometimes I've realized, but that's been the exception, that PTS, patellar tendon shortening, and the same would apply to PTA, will tighten rectus and can flex the hip. Remember that I said that right at the start of the talk. I'm not concerned about stiff knee gait after PTS. I'm concerned about a flexed hip. Sometimes at the same time, what I do is release rectus femoris proximally. But I don't worry. I want them to have a stiff knee gait for a year or two because I want to be sure that they're not going to relapse crouch again. and sometimes I see that they have a stiff knee gait and that they're wearing off the tennis shoes and they're spending a lot of money on that. And I beg the families to give me another year or two before we do anything to improve knee flexion in swing. Because the last thing I want is to put them in crouch again.
So one question from the audience, Dr. From Hyderabad is asking, what technique of patellar tendon shortening or advancement do you do?
Well, I use the one that we showed in 2000 at Posna, and I apologize again that we never published it. But it's a simple technique. We basically, this is your patellar tendon. I have the graph, but I won't find it just now. But this is your patellar tendon seen from the side. We cut it approximately in half, and we attach the distal half to the distal pole of the patella, and the proximal half on top of the distal half and into the tibia, using ethibond or more modernly Ticron or fiber wire or fiber tape. But when we started this thing in Brazil, in the first few years, we're so scared that the patella was going to the patellar tendon was going to stretch out again that we put a wire through the patella and incorporated the patella into the plaster. And we left the patient in a plaster for 6 weeks, and we never let the patient flex the knee for another 6 weeks on top of the plaster. So the patients never flexed their knees for 12 weeks. So the first thing that Kerr asked me when I introduced this to Melbourne, he said, Paulo, these patients will never bend their knees again. But they do, because think with me, we spend our entire lives trying to extend knees in CP. Isn't it true? All of you there?
Yep.
Knees were designed to bend. If you flex the knee about 7 degrees, it becomes unstable into flexion. So knees just want to bend, all right? So this is what I continue to use. The only difference is that nowadays we don't pass the wire through the patella anymore, because these fiber wire and fiber tapes are very powerful suture mechanisms. But I continue to be old ways. You know, in Brazil, when Brazil used to play good soccer, which we don't remember anymore, we used to say, if a team is winning, you don't change it. So the first cohort in Brazil worked pretty well. The few that I did in Melbourne seemed to work relatively well, except for 1 or 2 that were a total catastrophe because I picked the wrong patient. And Kerr advised me that I was picking the wrong patient, and I didn't listen to him. But the few that I did were doing okay. And I did not change. I tell the physios, please let the patient actively start bending the knee. Don't go asking them to go, you know, to kneel, to crouch. Don't do that. Let's do it gradually and very slowly. And in doing so, we have not seen the patellar tendon stretching too much. We've seen it stretching a little bit, but the crouch has never relapsed.
So what's your timeline, you know, protocol after a patellar tendon shortening procedure? What happens?
So again, in the past, we used to use a long leg plaster and let them start walking as soon as they tolerate it, even with the osteotomies, because we always used the blade plate, the simple, good, old, cheap, effective, safe blade plate, not the new stuff that is around these days. We use it for the femoral osteotomies, proximally and distally, and they work just fine. And in Brazil, as a third world country, I'm not postulating that, but in those days, 25 years ago, we even reused the plates a few times because we didn't manufacture them then. Should not be applied anymore these days. But so we put them nowadays we put them in a knee splint, a knee immobilizer, a long one. And I ask them to start standing as soon as they tolerate, but I ask them not to bend the knees for 6 weeks. And that's hard. You need a wheelchair that has, you know, leg support or boxes or whatever is feasible to keep them straight. But it works. And if you see, when we first published, when we presented our paper, we didn't have, I remember our paper showed there was one late infection with the suture material, and there was one heterotopic ossification at the tip of the patella, which is one of the bad complications that our predecessors reported in the past. We didn't
Okay, so one question is, what are the indications for isolated patellar tendon shortening procedure?
That's a very good question, and one that I was hoping you would ask. To the audience, we haven't talked about before this conference. Okay, this is not scripted. When you do those, what I humbly think that it's the right doses. When you do the semi-T, and then plus or minus you do the guided growth when it's necessary, and you correct all the levers and everything else, we don't have very severe knee deformities left. They're not so severe. I remember in Melbourne, and again, Kerr might correct me in a way, the other. Kerr sometimes likes to say the opposite. Kerr and I have worked together for nearly 20 years, and we don't agree in 5% of what we say. And he says that it's because I haven't learned, and I say that it's because he hasn't learned yet. But we didn't see a lot of severe crouch in Melbourne. Did you see it, Ratna? The ones that we saw were the ones coming from abroad, from other countries, other regions of Australia, etc. But in the state of Victoria, doing the right thing by the calves, doing the semi-T transfer because they incorporated it very nicely there, and they all trusted and believe it. We don't get to that point where that I know everybody sees, and I'm seeing it here in New York as well. Those horrible crouches with 40 degrees of knee flexion deformity. So because we don't get there, in some cases, we don't need the supracondylar extension osteotomy. All you see is, you fixed everything else, and you have a full knee extension of 5 degrees of knee flexion. You do the PTS, and you keep them extended for 12 weeks, and that takes care of the 5 degrees of knee flexion. So that's why it's PTS plus or minus supracondylar extension osteotomy these days.
So, Paulo, the next question for you. Literature seems to suggest knee extensor dysfunction during sit-to-stand transfers after the extension osteotomies in patella tendon advancement.
And this is a proof again. Yeah, this is a proof of these groups' dedication to cerebral palsy and their honesty, and how they really strive to tell everybody all the good things and all the bad things. I have a problem in this area, and the problem is that in Melbourne, I didn't do a lot of these surgeries, because in Melbourne, in Victoria, as I said, we didn't have a lot of these patients. In fact, we had very, very few, because Kerr went there first. He stopped all the TALs. When I got there, we became more conservative about the hamstrings, and then we started doing the semi-Ts. It took me 2 years to convince Kerr to stop doing hamstrings lengthenings and do semi-T. But Kerr is a brilliant man, and he embraced it. So, and he was the guy who pushed for the paper that we published eventually, because I'm not a good paper publisher. And but the truth is, we don't have this experience, and I don't have it because in the last 20 years I haven't needed to use this stuff very often. So this is a surgery that we we promoted first and again in the 90s. And this is a surgery that I don't use much anymore because the surgical dosing that we use when we have crouch surveillance, we think works pretty well. So what's the dose? I think it's, the dose is, technically speaking, I used to measure the length of the patellar tendon in the beginning and make a few calculations to try and reproduce the, in those days we used to use the insole index, not the other index. But nowadays, the ones that I do, I just cut the patellar tendon in half. It's the distal segment of the patellar tendon that you cut that determines where the patella is going to lie. So again, this is the patella seen from the side. We cut it in half, okay? We cut it in half. It's the distal half of the tendon that goes under the patella that tells you where the patella is going to stay. The other half just makes it stronger and more reliable. So I for many years now, that's all I do. I don't make it too fancy.
So, which means all the angles and measurements which we do to know the position of the patella, you know. So
well, we measure them post-operatively, and they look pretty good.
Okay.
But I think what I wanted to say, I think the most important part of this message is that, I don't know if I managed to say that to you all, this is a dangerous operation. It's not an operation for every day. This is an operation that was abandoned in the 60s and 70s because it caused too much trouble. We thought that we had the right dose when we understood the other problems that were going on with the kids, the levers, and etc. And we think we did a bit better, but you can tell that these studies are showing that it's not all that better. And that's exactly what I want to say. Patellar tendon shortening and supracondylar extension osteotomy should not be seen as the first dose. Only in rare cases. This is the message that I want to transfer to all of you. I've learned now, and I've been around enough, that the places I go, anybody who has crouch, and I was going to put another X-ray that I had found on the internet. The kid had a patellar tendon shortening, and he was 11. He was 11. This is, in my opinion, this is wrong. You can fix that knee flexion with procedures that have not been abandoned twice in the past. You can do semi-T. You can even, if you are a conservative person, you can even lengthen the hamstrings a little bit. Don't tell me because I'll be mad, but you can do that. As long as your pelvis doesn't do what that pelvis did with that boy that I showed you. But this operation is not all that, you know, it's interesting, isn't it? Because we were so happy when we showed this for the first time, and then Gillette showed it a few years later, and then the whole world started embracing it. I said, oh, we did one good thing in life. And then I realized, no, we did a horrible thing because now everybody uses it as like water and sugar. But that's not what we tried. That's not what we said 25 years ago or 20 years ago.
Paulo, as we know, the natural history of many untreated or inadequately treated children is crouch. So is there any way that crouch can be prevented by strengthening exercises, splinting? We've already spoken of surgeries, but any other thing that can be done?
Ooh, that's a difficult one. You guys always ask me difficult questions. I think, you know, Dr. Freeman Miller has a paper, if I'm not wrong. You know, I've learned so many things from Freeman over the years. It's not funny. But I think he has a paper showing that in some cases, and I apologize if it's somebody else. That in some cases, crouch doesn't progress. And I was just invited to review a paper for publication where this group of authors basically said that crouch doesn't get worse, which it depends. If you have a slim GMF's 1.5 or very slim GMF's S2 who's strong, who doesn't have a lot of spasticity, it may stabilize and get better. But if you have someone with tons of spasticity, lever arm dysfunction, and it's going to get worse. It's just a matter of time. People who say that it doesn't get worse, in my opinion, are people that don't follow the patients like we do in the gait lab, for 1 year, 2 years, 5 years, 10 years, 15 years, and continue to follow them as adults. So can you prevent it? Well, you can prevent it by not causing it. Okay? And unfortunately, most of the crouch out there is caused by us. Okay? Unfortunately, and still, despite people having said that for nearly 30 years now, you can prevent it by monitor it. If you see a child at the age of 8 or 9 or 10 who's starting to bend their knees for whatever reason, you have to understand what's the reason and treat the reason, not the hamstrings. Okay. So we occur in Pam Thomason in their first cohort of patients in that very famous paper that they published quite a few years ago. They did this. They got one group of kids and they put these kids through intensive physiotherapy. And the other group of kids, they operated initially and reevaluated them after a year or two. And they seem to have shown that you can strengthen, but if the feet are pointing east and west, if the hips are turned in, if the patella has already climbed up, if you have planovalgus feet, it's not going to do anything. Okay, it's just, exercise is good. Remember, the first thing that we say in orthopedics is that movement is life, life is movement. And I still believe it. I'm not saying that a child should not have it, but to tell the parents that that's going to solve the problem, I think is not ethical. I think you need, it's a biomechanical problem in many cases. And until the biomechanical problem is fixed, it's not going to be fixed. And that's been one of the many great contributions from Dr. Jim Gage, David Sutherland, and others, and Drs. And Freeman Miller and others. That they've been using gait analysis for nearly 40 years. 40 years. It's not new. Okay, it's older than MRIs, and they've taught us all along and for many years what's wrong. You just go to Amazon and get Dr. Jim's Gage book on mechanisms of pathological gait, and it's all there. And I've studied it, I learned it, and I tested it, and to this day, nothing that Dr. Gage told me I or anybody else has managed to prove wrong, as far as I know. The only thing that I have an if with him, and he knows because he's my mentor for life. He knows that. He said, "Paulo, why did you continue to do semi-T transfers?" And I said, "Well, because it's one of the best surgeries that you taught me." And I think I'm getting him around that idea, and hopefully helping more children with that.
So, Paulo, coming to planovalgoid feet in crouch, how responsible are they for creating crouch? What preventive measures can we institute early to prevent a severe midfoot break? What are your orthotic recommendations, your choice of surgical intervention, and in a blown crouch, with the knees, the torsional issues, and the broken feet? Do you do the foot first, the knee first, or both together?
Well, that's something that changed as well a little bit. And when I left Minnesota and Chicago, I went back to Brazil, and I was literally, as I said during the talk, doing SEMLs. We tried per the masters. We treated everything at the same time. I even did a couple of rectus transfers myself in crouch. That's how I learned it, the worst possible way. But then these were probably the first 10 years of my life. Then during the second 10 years, I realized that I was doing too much. I realized that very often, and more often than not, when you get the knee straight, you don't need to do rectus transfer. I realized the concept of dose. In fact, the concept of dose came to me in my final years in Brazil when I realized that sometimes it was too much, sometimes was not enough. And I said, what's wrong here? There's a problem here. And that's when I came up with this concept of dosing. I said, well, we can't treat everybody the same way. And then, of course, when GMFCS came about, it was one of the big revolutions to the field of cerebral palsy. It's one of the most helpful things that ever happened to us. Then we said, okay, because before that, the concept of dosing was all up in the cloud, because, a good diplegic to me, I'm an optimist, may not be the same as a good diplegic to a pessimist. So, but then GMFCS came, the FMS came, and we said, well, now we can tailor the doses, not only based on what we think we know, but based on the GMFCS as well. So, how can plantar valgus feet create crouch? Well, they're a bad lever. In the plantar flexion knee extension coupling mechanism doesn't work very well if the foot can't push the floor because it's too floppy. Or because it's not in front of the knee. If the feet are turned out, they're actually pushing the knee more into valgus than into extension, or a bit of both. So until the feet are in front of the knees, they're not good levers. Now, the better the GMFCS, the more the kids can cope with that. Because more often than not, the better GMFCS, the better selective motor control. It's not 100%, like nothing is 100%. This is not a 100% rule. But if you have good selective motor control, if you're slim and relatively strong and not too spastic, and you're a good GMFCS too, a little plantar valgus foot doesn't make any difference. And you saw that patient that I showed on my talk. He had externally rotated feet, which were also very bad in plantar valgus feet. And I have the x-rays, I could have shown it. But he has dystonia. And you know what dystonia does. Dystonia drives things in whichever way dystonia wants to do. That's why I didn't touch his feet, because sometimes a plantar valgus foot is only a plantar valgus foot because the tibia above it is externally rotated. There's no other way or no chance for this feet. And that example is a good example. This kid had externally rotated feet because of the tibia. Therefore, they had a rollover valgus mechanism. And as soon as I brought the tibia, not as soon, but over the years after I brought the tibia in, and I promise you I didn't touch his feet at all, the feet, bang, they went back to a very good position, and they will never require surgery. They're good levers, they're in front of the knees. So that's the beauty of this area. That's also the challenge of this area. When can you look at a plantar valgus foot deformity and say, this is what's causing it? Well, that's what's causing the crouch. Well, when you have John Davids called the Diagnostic Matrix, which is what Jim taught us way before anything. You need to look at the X-ray. You need to look at the physical examination. You have to look at the gait data, and you have to look at the physical examination under anesthesia to make the final decision. It's not plano valgus foot. All right. Preventative measures. If the child is young, you don't want to operate. I personally don't like to operating on young feet because I think surgeries are totally unpredictable then. And they grow out of them, they collapse again. So I tend to defer, for instance, bony operations until they're 11 or 12 or even older. Sometimes you have to do them early because the feet are so misaligned. But you can use a solid AFO. All right, a solid AFO will help if the feet are not turned out. If the feet are turned out and you put them in a solid AFO or solid AFOs, they're only going to cause more valgus moments at the knees and rotational moments for instance, Sylvia Ampou showed many, many years ago in spina bifida. So do you understand that it's not one recipe? You have to put all of these things into, you have to understand the problem and then calculate the dose. Surgical interventions of choice. I continue to more or less do what Dr. Jim Gage taught me. In GMF-SES2s, if the feet are very collapsed, I tend to do an oscalces lengthening because that adducts the forefoot. Therefore, it brings the forefoot or the 4 feet in front of the knees. Okay, that's why I do the oscalces lengthening, not to make the X-ray look better, but to make the foot point in front of the knee. If that's not enough, then you have to derotate the tibias at the same time. In GMF-SES3s, I tend to be a bit more aggressive, and I do oscalces lengthenings and subpatellar fusions at the same time. Now, there are all those problematic cases. What if the medial column is so breached? Can we do talar-navicular fusions? I think you can, depending on the severity of the deformity, the GMF-SES, and so on. So you increase the dose as needed for that one case, okay? So that's why it's different. That's why the principle of dose is important, because it's what needs to happen to that patient, not to all patients. But it also makes it very difficult to prove, because you would need 1 million randomized controlled trials with every one of our hypotheses. And of course, that will never happen. But I think the Melbourne's result, in many ways, are a product of this concept of dosing, and they published them. So perhaps the concept of dose, best data that I have is what Kurt Graham has published with mine, Bice, and everybody else's their techniques.
I follow. I've written this after reading one of your articles. You can correct me if I was wrong. The preferred method, according to you, seems to be a semitendinosus transfer and a distal femur guided growth around 9 to 12 years of age, depending upon the requirement. But after doing these procedures, what % of children at a later date will still need a PTS and an extension osteotomy?
I will tell you, I will answer that. Well, firstly, I don't know. Secondly, I'll tell you my good old stories. One of our very brilliant fellows, Dr. Ben Shore, who now is in Boston. You probably all know of him and about him. He's become a very big name in cerebral palsy here in the United States. He's a genius. He's dedicated as nobody I've ever seen before. He's brilliant. A couple of years after he finished the fellowship with Kurt and I in Melbourne, he came to me and he said, I'm going to Gillette to learn how to do PTA and supracondylar extension osteotomies. And that took me a little bit by surprise. And I said, well, why do you have to go to Gillette? You know, we know how to do it here. And then he said to me, Paulo, in the year that I was there as a fellow, you did one. So he never learned it from me. So in Melbourne, Melbourne was a paradise in terms of population-based control, investigation, research. And having Kerr around, you couldn't have asked for more. He was so diligent to, in keeping everything under control. He tried to keep me under control, but he couldn't. And so we basically treated the kids the way we think they should be treated: dosing, avoiding this, avoiding that, doing this and that. And we didn't see crouch. I mean, we saw one or two, but not the ones that you guys see all the time. And I'm starting to see here in New York. I'm actually scared. I think I need a fellowship as well with someone to learn how to do these things again.
And the second part of the question, I have read that you are not doing semimembranosus aponeurotic lengthening anymore.
No,
Could
I
you
stopped.
shed some light on it here?
And I think I stopped when you were in Sydney, weren't you?
No, I was in Melbourne with you.
You're in Melbourne. Sorry, you can tell that my memory is fading. I stopped because I saw data in Sydney that basically told me that my semimembranosus lengthenings were still dropping the pelvis forward. So I eventually stopped doing it. And it was funny when Kerr and I were together operating SEMOs, and he would try to charm me into doing the semimembranoses, and I didn't want to do. And sometimes he's very cheeky, Kerr. He would say, "Okay, Paulo, you're tired now. Why don't you go home? You can go take a shower." Ratna would remember these stories, I'm sure, and so would you. Why don't you go? I said, no. If I leave it, you're going to lengthen the semimembranous, and we can't do that. And I'm not sure that it's the right thing or wrong thing, and if it's panacea again, if no one needs not to have semimembranosus lengthening. But one of the many things, the numerous things that I've learned from Jim is that it's better to leave a muscle that needs to be lengthened unlengthened than to lengthen a muscle that doesn't need to be lengthened. Okay? That's one of the many principles that I've learned from Jim. And let's see it. If I do the semi-T transfer, if I do the guided growth, and if semimembranosus proves to be a devil a year or two later, you can do a semimembranosus intramuscular, fascial lengthening as a day procedure. You put them in a Zimmer splint for 2 or 3 days, and they're over. But if you do it and the pelvis tilts forward, then there's nothing you can do. Lengthening psoas is not going to push the pelvis backwards. People think, oh, I'm going to lengthen psoas, the pelvis will go backwards. Well, do you know of any muscles that can push things? No, muscles can only pull. So in the past, people have written papers saying, oh, we did 3 hamstrings and psoas, see, and the pelvis tilted forward. Well, you're killing 3 guys here, and you're doing a little bit to this one, and you think that the pelvis, if you think where the center of rotation of the acetabulum is in relation to the pelvis, it's slightly posterior, and the pelvis will tilt forward, because that's where we've come from, evolutionary speaking. Yeah, that's pretty much it, Ratna. I think it's a smaller mistake. I mean, the right thing to do is to do the right thing, to lengthen the ones that need to be lengthened and leave the ones that don't need to be lengthened alone. But if you're in doubt, and if you don't know, the problem is that with the younger surgeons, they look at us lengthening that little fascia and the muscle stretching a little bit, and our surgeries, they look and seem very benign. And they say, oh, I've learned just a little bit. I'm going to do a little bit more. But the truth is, our surgeries, muscle lengthenings are so powerful, and they can weaken muscles. And if you see semi-T and semimembranosus, the muscle fiber, semimembranosus, and again, Dell published a paper like that, semimembranosus is way much more prone to lengthening, prone meaning it's way much more sensitive to lengthening than for instance, semitendinosus, because of the rapid twitch, slow twitch composition of and the pennation of muscle fibers.
So, Paulo, I'm going to ask you some of the questions from the audience, and since we are a little short of time, since we are a little short of time,
very hard.
Yeah. Can we have quick answers, to these questions?
Okay.
So this question is from Atul Bhaskar in Bombay. So if you are doing distal extension femoral osteotomy as a salvage procedure, what's your landing point? You aim for complete extension, slight flexion, or slight hyperextension? What's your choice? Quick choice.
Slight hyperextension, depending on the age.
And Sampat from Bangalore, how do you manage recurrence of a crouch after doing distal femoral osteotomy and PTS? If the crouch recurs, how do you manage?
That's a little bit of a secret that I hope Dr. Jim Gage doesn't listen to this. Dr. Jim Gage told me never to touch the biceps femoris. But in about half a dozen cases, I noticed that I was not winning and that biceps was a bit too stubborn. So I went very high up on biceps, mid-thigh, and I did a fascial lengthening. And it seemed to have worked a little bit. But I have many cases that it didn't matter what I did, the kids did not get out of crouch for other reasons, for balance, for selective motor control, for vision problems, for weight problems, etc. Because they were very severe GMFS3s, etc. Well, I cannot hear you, Taral. Your microphone is off.
Children with extremely severe crouch, with knee flexion deformity more than 60 degrees, or in stance phase they have knee flexion more than 60. And how would you plan to treat them? Single stage surgery. Is there a role for a posterior capsular release of the knee in these patients?
Dr. Luciano Diaz used to do posterior capsular releases in spina bifida, and I learned it from them. I haven't used this technique in CP. I can't speak for it. The problem with 60 degrees of fixed flexion deformity is that you need to extend a lot, and you need to shorten the femur a lot so that you don't cause neuropraxia of the sciatic nerve, which is a complication that I've had, and which is a dreadful complication. So I think you could, at 60 degrees, you could do a semi-T transfer just to help a tiny little bit. You probably get 1 degree out of that surgery, but at least semi-T is not going to be there fighting against your patellar tendon shortening afterwards. And then what you have to do is a massive supracondylar extension osteotomy and PTS. Now, I understand that in many parts of the world, this is routine, and this could be happening in GMFS2s. I wonder, when is it that we have to accept that we're going to cause more damage than help, than harm? We're going to harm more than actually help. And the few that I've seen, in Brazil, we had a few to begin with, and we dealt with them. We had a lot of complications. In Australia, I had one or two that went relatively well. One had a sciatic paralysis for years, and he's now probably close to 10 years post PTS or more. And one of his feet is still numb because he had such gross deformity. So 60 degrees is tough. And I would still use the principles of sparing the hamstrings and correct the deformity through the osteotomy and do what needs to be done to the patella tendon.
So some more questions from the audience. I think a few of the last ones. How is the hip extensor weakness addressed? Ouch.
Pardon me, can you repeat the question?
How do you address the weakness of hip extensors?
How do we treat it?
If the hip extensors are weak, how do you address them?
Well, the first way to address it is not to cause it.
Can you hear?
Because once it's done, it's done. And
the question is, how do you address the weakness of hip extensors, the gluteal weakness?
How do I address?
Yeah.
I think the only thing you can do is to try and strengthen it. We did, and I still do a little bit of extension. I add a little bit of extension to the femoral osteotomy to try and help that if that's the case. But you can only do that in younger children, because if you do that in older people, you'll probably create anterior impingement, acetabular impingement, which is not a good idea. So every child with CP has weak hip extensors. That's why we have to protect the hamstrings.
Ratna, you have any more questions? I think it's almost 2 hours. We have been listening to Paulo, and he's been patiently answering all our questions. I would request Dr. Dhiren Ganjwala to, do the final part of this webinar. Thank everybody. Before we do that, I want to tell the audience that tomorrow same time we have a very interesting webinar on DDH management under 3 years age and its prevention. Dr. Alaric Arujis is the moderator, and we have Kishore and Shankar, both from USA, who are the speakers for the session. Dhiren bhai, over to you.
Yes, thank you, Paulo, for wonderful exposition about the topic, and like you gave a historical perspective. I came to know for the first time that you were the person who was like starting this journey of patellar tendon shortening. And now you are warning us, please don't do it too aggressively. Thank you very much for sharing your experience and knowledge with us. Good night.
Good night. Thank you all for listening. Thank you. Bye-bye.
Good night. Thank you. Thank you.
Bye-bye.